Okay, ladies and gentlemen, friends, colleagues, welcome to this second webinar series, an opportunity to discuss and talk through our public consultation draft of the review of the guidelines for the detection of prostate cancer. Thank you very much for joining us. Some of you I can see were at our session a couple of weeks ago, and some of you are new to that. For those of you I'm yet to have the pleasure of meeting, Jeff Dunn's my name, and it's my great pleasure to have been associated with the PCFA for many years and to be playing a role in the review of the guidelines. We've got an hour session this afternoon. It's going to be mixed up and lively. We've got a panel of people to assist with providing some information, and then for our subsequent Q&A, I'll just quickly introduce them and then we might get on to other stuff. So we're joined by Professor Peter Heathcote, an eminent urologist, well known throughout Australia and globally for his work in prostate cancer, a leading clinician and clinician researcher. So Peter's the chair of our expert advisory panel. So Peter's there. I think Peter would be known to many of you. We've also got Associate Professor David Smith. Now, David was meant to have been at our first one, but we had some cross-Tasman internet hiccups. I suppose that's the polite way to put it, isn't it, David? And David was unable to join at the last minute. But David's here with us today. Happy, ready for action. And in fact, David has also got a brief presentation, which we'll see a little bit later on, which details for you, and we thought you might be interested in this, the actual methodological process, without going into too much content and too much depth, but just to give you some idea about what it takes to review these sorts of guidelines. And of course, someone who needs no introduction, the boss, the person in charge of everything PCFA, Anne Savage, our CEO. Anne will give a brief bit of update on what's been going on and other things, and certainly join us in the panel, which will be terrific to hear from her as well. Friends, just a bit of housekeeping on these virtual things, which are very convenient. But first of all, if you're not talking or not intending to talk in the very near future, please do keep your microphones turned off, and I can see that most people have. So look, thank you for that. It just makes it easier. When we get to the Q&A, if you do want to actually ask a question or make a comment, can you please use the hands up function? I think for all of us, it's, you can get that down the bottom of the screen there, and it just makes it easier, particularly when we're going through to make sure everyone gets a turn. At the same time, if you like, or you're finding it hard to use the hands up function, you can use the chat function, which is open. So you can use that, and you'll see already in the chat, Sven's put in a welcome message to everyone. So that's nice of Sven. Sven's working in the background. He makes all these things happen. So thanks, Sven, from everyone. And of course, if you don't get a chance to ask a question, and if something comes to you afterwards, or the chat we don't get a chance to get to all the questions in the chat, please do take the opportunity to email us at research@pcfa.org.au, and we will respond. So I think Sven will put that address in the chat room as well, because he's very helpful like that, and that will appear at any moment. So there's just some housekeeping. We'll do our best to keep the time and give as much of that time as possible for the Q&A. So again, we're here to talk about the consultation draft of the revised 2016 guidelines, which we've retitled the 2025 draft guidelines for the early detection of prostate cancer. Very briefly, because some of you will have heard this last time, but for those of you that are joining us this time, first time around. So the current guidelines were released in 2016, and a lot has changed since 2016. there is a definite need to review it. The evidence in relation to prostate cancer detection has changed. There's been significant advances in technologies like imaging, MPMRI. There have been significant changes in clinical practice. For example, a shift from transrectal to transperineal biopsy. For example, significant increases in the employment of active surveillance as a treatment option. And there's also been changes in the community, in our expectations, our understanding, and what's going on with regard to our attitudes and approaches to testing and to the early detection of prostate cancer. So because of all of those things, we need to make sure that the guidelines that are out there being used and applied through our primary health and specialist settings are up to date, are evidence-based, are uniformly applied, and we also need to make sure that on this occasion, unlike previous ones, we have consumer companions, and we make sure that there's a public education awareness campaign. So all of that is rolled in. To do that, we receive funding, and myself and others on the call were very much involved in lobbying the federal government for support. 3 years ago, we got that support from the government to review these guidelines. We have undertaken an exhaustive process of evidence review, of systematic review, of involving experts, consumers, health systems to help us produce those guidelines, which we released for public comment around 4 weeks ago, before Easter. I can give you a very brief update before I throw to Peter, but I'll give you a very brief update so far on what's come through. So we've had a significant response to the guidelines, and we're delighted about that, as at yesterday. So there will have been more coming today, but as at yesterday, we have had 171 submissions commenced. We've got 100 completed submissions in terms of consultation submissions to the guidelines, which we're actually delighted about. Most of those at this stage are from consumers, a bit over half. The next biggest group after consumers are our general practitioners and general public, which is good to see. Some specialists coming in, which we're also delighted about as well. We always expected that the first part of the consultation period would be individuals, families, and practitioners, and that the bigger institutional feedback we'd get a bit later, because they tend to need to go to committees and consult more widely within their membership. So that's happening, and we are starting to see in this last couple of days institutional feedback come through to us from organisations like ESANS, so the urologists, and just last night we received a very detailed and favourable submission with some terrific suggestions from a multicultural organisation, a major one based in South Australia. So these are all starting to come through. We're delighted with that. I must say there have been over 330 individual comments that have been made to us about the guidelines so far. By far, the majority of those are about the implementation of the guidelines. About what we do after, about a consumer companion, about education awareness, about all those sorts of things. And in a way, that's not so surprising, perhaps. Next is about stuff around PSA testing itself. So there's been quite a bit of feedback, around what's involved in the testing, about age, about frequency, and all of those sorts of things are very important for us to make sure that we get that feedback from people out there in the community, from consumers and from personal groups. And another a significant proportion of the feedback so far has been about clarity, about reminders to us to make sure that the guidelines are clear, easy to understand, easy to interpret, and well understood. So that gives you a bit of a flavour about what's coming through. And I must say, to have 100 completed submissions at this point in time is exceptionally encouraging. I should also say that the vast majority are constructive and positive. And when I say constructive, I mean offering terrific suggestions about how we might improve or things you might think about. And that's been wonderful to see. And we'll fold those in. Others have been very positive about our approach and what's been going on. So there's still time to go. The actual consultation period finishes at 11:59 p.m. on Sunday week. So as Peter Heathcote helpfully reminded, oh no, it wasn't Peter Heathcote, but I'll blame him anyway, he's got broad shoulders. But as Peter Heathcote helpfully reminded some people I was talking to earlier today, you've got 2 weekends. So there's plenty of time if you want to get a submission in and you haven't done it already, and we encourage you to do so. All right, why don't we now turn to Peter, maybe get Peter, if we can just get comments from you on the importance of the guidelines, what you see being the big transitions and the big shifts, and any messages for those on the call today.
Thanks, Jeff. Welcome everybody, and really appreciate everyone giving up their time on a Friday afternoon. Remembering it's Poets' Day, so we've got things to do shortly. Look, the big lesson that we learnt from 2016 was that we needed to have a clearer and more succinct set of guidelines that directed the general public, but more importantly, that was widely adopted and accepted by general practitioners throughout Australia. And Jeff has, as always, underplayed how important a role he's played in all this, because we've really engaged with the College of General Practitioners this time. They're on all the major committees. In fact, Jeff and I are meeting with College of General Practitioners for a one-on-one, if you will, with them on Monday to run through feedback, because we really want them on board and we really want them to take ownership of this. And also, David and I are sitting in with the College of General Practitioners, rewriting the patient education and information booklets. So hopefully we'll get it right this time. We'll certainly get a better product. In terms of changes, Jeff's touched on it already. It's not a PSA testing guideline anymore. It's a guideline for the early detection of prostate cancer. And we've delivered those guidelines in separate tranches, if you will. There's the first tranche that talks about risk and decision support, because both risk and decision support permeate through the whole guidelines. There's a section on DRE for primary healthcare, but also a note that we're not saying don't do a DRE as part of the assessment, but we're just saying don't do a DRE as part of a screening or testing program. And then there's the all-important PSA advice, and that's been written with the busy GP in mind. And you'll see flow charts that we've made. We want to be able to help GPs make that decision in the short time they have, in a clear and succinct recommendations. The rest of it, MRI, Jeff's touched on that. MRI has been a big game changer. I go around to international meetings in Europe and North America, and they're still having conversations about MRI that we had 5 years ago. We are so lucky in Australia to have access to MRI, to have access to transperineal biopsies. Anne Savage very kindly got me the Medicare figures out earlier this week. 97% of prostate biopsies are now done through the transperineal route. That is just world leading. That's better than anyone else will ever hope to get. And we thank the consumers are on the MSAC committee for that, who drove a lot of that. Active surveillance is the other one. We're doing a lot more active surveillance in Australia. It's in the mid 80%. David Smith, you'll know from the Prostate Cancer Outcomes Registry those figures, but it's around that figure. And again, that's world leading. So messages, we want to be clear, we want to be succinct, we want it easy to read and readily adopted in a busy format for GPs. We will be writing a consumer companion for consumers as well, but that's about all. And the Holy Grail, Anne Savage, this is your job and mine and Jeff's, is to bed this in, get it accepted by NHMRC, then let's move on to the next phase and get an Australia-wide organised testing program so we can halt the tragedy of men presenting with metastatic disease, save billions of dollars for the Australian health economy by moving to early detection, because we are now not doing so much harm. I'll stop. I'm raving. Thank you, Jeff.
Yes, Peter. As always, succinct and to the point. Thank you, mate. And your contribution to this review has been outstanding, and we do appreciate it. I think you provided me with an excellent segue when you mentioned that there's jobs for Anne Savage to do. So why don't we throw to Anne? And from your point of view, a bit of an update and some observations.
Thanks, Jeff, and thanks, Peter and David, to all of you for the work that you've done, and also to everybody here today who has already submitted comments or who is planning to, and who has influenced the process. I know that PCFA may not have picked this up as aggressively as we did going back 3 and 4 years if we hadn't been urged to do so by our support network. So we thank you. I guess what I'll say is that I think for too long we've tolerated a primary care approach to prostate cancer that hasn't kept up with the evidence. And that's why this work is so important, and it certainly will inform general practice moving forward. At the same time, what I can tell you is that we are canvassing options for what a register of prostate cancer testing may look like in Australia, and what that could mean in terms of reminders for men and helping to coordinate prostate cancer PSA testing in a far more organised fashion than it's ever been done before. So we are looking into that, and we will tell you more as soon as we have worked those discussions through with the Department of Health and others. Implementation is important. You know, public policy isn't worth the paper it's written on unless you fund it adequately. And I think that will be a large part of the challenge for us moving forward. We've retained Mark Butler as the Health Minister, as many of you will know. We do also have now a special envoy for men's health, and I've spoken to him today about organising a meeting soon, and he's very eager to meet with us, which is great. That's basically it from me for now, and I'll hand back to you, Jeff, to hand over to David.
Thanks, Anne. I appreciate it. I mean, Anne's work in wrangling our policymakers is second to none. So in terms of the task ahead with getting funding, changing practice, we're in good shape there, and certainly very proactive. So it's nice to see we've got the new men's health, the Prime Minister's men's health envoy, I think is the title. So let's certainly engage as early and fruitfully as we can, which is great. Okay, so what we might do now is just turn to David Smith. And David, as you know, is a technical team lead based at Daffodil Centre. He's got a long history in prostate cancer. He's been part of our scenery, a valuable part of our team for many years, and his work in leading the technical team in the review has been sensational. And David might just run through the methodology for us. David, over to you, mate.
Thanks, Jeff. Thanks for that introduction. And I am really going to keep this very top level, because I could spend probably hours just walking through the methods that's required for the science behind ensuring that we have evidence at the very center of our evidence-based guidelines. So this is the top level to kind of provide the structure that speaks to the way in which we went around this process. Some of you might have heard Norman Swan several weeks ago talking on the ABC on the health show around the guidelines, which was really good to get some coverage. And he mentioned a little bit towards the end where he said that there's within the guidelines, he was a little concerned about some of the way in which we'd landed on consensus-based guidelines. And he said, oh, we used to call this at medical school GOBSAT, where GOBSAT stands for good old boys sitting around a table. Now, we do have some consensus guidelines, and I'll talk about how we arrived at those. But essentially, at the heart of this is the evidence and the evidence-based guidelines, and it's really important that we do recognise that it's the evidence that's driving the recommendations that go into this report. And so my job in the next couple of minutes is just to walk you through the way in which we've arrived at that evidence. So first up, who am I and what am I doing here? Well, I'm currently the interim deputy director of the Daffodil Centre. We're a joint venture between Cancer Council New South Wales and the University of Sydney, and we have expertise in epidemiology, biostatistics, and specifically for the role in this job, systematic review specialists. So this is the sort of the team on the right-hand side from the Daffodil Centre. This represents the team at the end of the process, and we had a few other people come through during that time, and I recognise them. But a largish team who essentially did all the hard work, and I'll show you some big numbers towards the end. The hard work in reviewing systematically the international evidence around the defined questions that were proposed to us through the various structures that we've got here. We were enormously grateful for being able to work with Jeff and Peter and the largest steering groups and expert advisory panels and working groups. Over 65, I think 65 people involved with that. So it's been a really fantastic process. My group has had previous experience working on the 2016 guidelines in prostate cancer. And since that time, we've also worked in bowel cancer, cervix cancer, and liver cancer, just to name a few. So we've got reasonably good credentials on the board about going through this process and ensuring it's done to the highest possible standards. And the pinnacle that we're really aiming for, and Jeff's mentioned a little bit here, is ensuring that we tick all the boxes that are required for the National Health and Medical Research Council, the NHMRC. That really kind of governs the process that we follow to ensure that everybody recognises the right process has been followed and that we've really arrived at evidence-based guidelines. So very top level, really, the process for a systematic review is a structured and scientific process that really starts with the definition of the purpose. And our original purpose, if you remember, was actually to review the 2016 guidelines on PSA testing. Throughout the process over the last year or so, we've really realized that that was a little bit focused and defined, and we needed to broaden this. And really, we've landed at this point at the end, which is far more achievable and successful and likely to translate better, is to talk about the early detection of prostate cancer. So throughout this process, we've been defining the purpose of what we've done. The second really important part of this process is to ask focus questions. And this really helps the science of it, because with a focus question, we can then go through and systematically look for the evidence. So our focus questions usually are focused on what we call a PICO question. And a PICO stands for four really important parts of the process. The P stands for population. The I stands for the intervention. The C stands for a comparator. And the O stands for an outcome. And each of those are really important when we do the next part of the process, which is search for the studies. So our technical team have to define, after working on the specific questions, then have to define their search strategies that take them to various different databases that search for the international published literature on the particular issues of those PICO definitions. The fourth part of the process really involves the selection of the relevant evidence, and there can be various different stages of that selection, from looking at titles through to reading the abstracts. And anyone who's familiar with the medical research realises that the abstract is essentially supposed to capture the essence of the paper, but often doesn't, and so often we have to go through and read the entire paper as well. You might say, does AI have any influence in this process at the moment? It hasn't, and we haven't used AI in any shape or form during the development of these processes. It's been human intelligence rather than artificial intelligence to do this. AI might be around the corner for this particular process, but at the moment it's really relied upon the expertise of our team. After selecting the right evidence, the team then goes through a very systematic process to analyze not only the benefits and harms, but also the other aspects of the paper in terms of critiquing the way in which the research is presented, the methods that we used, and what the outcomes are really coming towards. That information is then passed back, and the way in which we've done it is to work very closely with each of the working groups to make those recommendations. Some of the time, as I mentioned before, we can make evidence-based recommendations. And those you will see throughout the documents. But in other times, we come up and we make consensus-based recommendations. So I mentioned before that we've got sort of two guiding principles behind us. The first one is the National Health and Medical Research Council, and they have a bunch of criteria that we really need to meet. They've got a guidelines for guidelines document, and we keep referencing back to this to ensure that the process that we've been following has really been met. And some of I won't run through each of these, but there are several that are really important, and I guess 4, 5, and 6 are the three that are really at the center of this. Is the systematic identification, synthesis of the best available scientific evidence that we then turn into clear and actionable recommendations in plain English for health professionals. And the following part after that from health professionals that we're talking about for the next stage is to turn these into consumer-based guidelines as well. And we're at point 6, which is the public consultation. So public consultation is a really important process deemed by the National Health and Medical Research Council to ensure that we've fully grounded the recommendations in the expectations of the population that we're servicing. During that process, we also have to get independent and external clinical review and incorporate all that into the dissemination and the implementation. So that's part of the NH and MRC process. Digging a little bit deeper, we've also been following a set of criteria that's been set out by what's called the GRADE recommendations, and GRADE stands for Grading of Recommendations, Assessment, Development, and Evaluation. So this is an internationally, scientifically recommended process that we've been following. It's like putting together a piece of puzzle to make a smart decision, and really the experts, or we've been looking at the evidence, gathering the research studies and checking how strong and trustworthy they all are. And this includes any risk of bias that is included in studies, the consistency and inconsistency, how direct or indirect some of the processes that we're looking at in Australia have been applied from some of the international studies. We look at imprecision and also assess any publication biases that come up from the studies. We then, as you will notice, make a recommendation. And this has been a really interesting process that we've been through. And it comes down to making not only a recommendation itself, but also providing a strength of the recommendation. GRADE has been changing, and it's actually been changing a little bit over the process that we've been writing these guidelines. And we now just have two choices to make a strong recommendation, and that essentially means that most people should do this, or a conditional recommendation. These used to be called weak recommendations, but that wasn't the right terminology. And a conditional recommendation essentially means that some people might want to do this depending on their situation. Conditional recommendations are usually assigned when some of the decision criteria in the bottom of those boxes around the benefits and harms and the values and preferences and the resource use and the equity, acceptability, and feasibility, where there's a little bit of doubt around whether those apply to everyone. For these particular guidelines, we haven't delved deep into resource use. We've really made recommendations based upon the best possible evidence. And we've also accepted where there may be some inequity issues, but that shouldn't be driving any of the decisions or the recommendations that we've made in these guidelines. So, summarizing the process and getting close to wrapping up my time, we've really done this systematic review, and in some cases, before we define the questions, we could say, is there sufficient evidence upon which to make a recommendation? And if so, we've made an evidence-based recommendation in blue. Some of the time, we just drew a blank and we found that there wasn't sufficient evidence to make those recommendations, and we've come up with a consensus-based recommendation. And in other areas where we didn't pre-specify a question, but we still have some evidence somewhere, we've made good practice points. And you'll see those throughout the document, and I think each of them play an important role to address some of the issues. So the last little input into the way in which the technical team has been undertaking its work. Here's just a bit of a dump on the workload that's undertaken for this review. And I don't think Jeff and Peter have seen this actually recently, so looking for their reactions. We undertook 17 independent systematic reviews, sort of 2 on PSA, 1 on DRE, 3 on MP-MRI, 5 on biopsy, 3 on active surveillance, and 3 on risk factors. So each of those was a considerable piece of work in itself. All up, we screened about 27,000 abstracts for that work. Full text for those, then processed to the next stage. So 1,150 of those needed to be read, and data extracted from those and synthesized into the process that I've just shown you before in respect of the evidence synthesis, the presentation of the technical reviews to each of the working groups reading them, assessing them, debating them, deciding whether the evidence was sufficient for us to come up with the recommendation, and then crafting the recommendations to get the wording right and to ensure that we've got forward process. So we think, well, we know that the process that we followed is up there and hits the standards that are expected, and therefore the process of the public consultation is really just, we hope to polish up the any of the minor pieces around the corners that really haven't hit the right mark. That's really it from my point of view. Jeff, back to you.
Thanks, David. Appreciate it. A reminder, David spoke about public consultation, but of course, you might remember that we've actually, this is our second one. We did a first one in the first half of last year, when we, just to make sure we got your views, consumer consultation right up front, and they've been folded into the process. And certainly now we're looking at this second one to make sure that we do everything we can to get those views from consumers, from interested members of the public, from health professionals, and of course from organisations out there. And they're still streaming in. But why don't we? And just a point, some of the early ones said that the documents are too thick. Can I just let you know that it's a requirement for us when we go out to public consultation to send out that level of documentation. So as you know, the actual guidelines themselves are 300 pages, but that's a requirement. We have to put that out there. The technical report, for those of you that are interested in that, is another 300 pages or thereabouts, which really details the work that David and that tech team have done. So it's been a mammoth piece of work. Anyway, hey, look, now time for Q&A. So are there any thoughts, comments, questions out there? Either raise your hands or go to the chat box. I'm just looking through. Tony, I can see Tony's got his hand up. Tony, please.
Good presentation. I was a little bit late getting in. I only got the message a short time ago. Yeah, look, this is such a relief to have this come in. The amount of times we talk with people about prostate cancer and trying to get through to them, it's a challenge. I should say I'm the chair of the Limestone Coast Prostate Cancer Support Group. Bit of feedback for you guys. We recently went to Lucindale Field Day and talked to a lot of men up there, and it was really comforting to see so many men stop and chat. It was about 6 years ago, most men had walked past. And there was about 5 of them that come up and had just been recently diagnosed with prostate cancer. Now, a couple of questions. There's going to be a process going through, and then documentation is going to be changed. Is there a plan for PCFA to change their pamphlets on PSA testing and guidelines and things like that? And if so, which I presume there is, but if so, what sort of time frame would that be?
Yeah, look, absolutely. And we've already started that process. So we recently discontinued the book about should I have a PSA test, and we've created a different brochure to send out. So we'll do that as quickly as we can, and our team is looking at that right now. But we're certainly well prepared. This isn't the reinvention of the wheel. We know how to communicate pretty well these days and how to do that rapidly, but it will be a high priority for us. The education and awareness piece around this will be critical. So this will actually be an area of focus over the next 6 months for our team.
Yeah, here. And Tony, just backing up Anne's comment there, I think Peter mentioned, for example, the RSCGP Monday, and a part of what the resources look like are coming into agreement with the RSCGP, so we're all on the same page, and where possible, we're going to have shared resources, saying the same, getting the same message out. Because part of the issues about the 2016 guidelines were, perceptions whether they're real or not, but certainly perceptions about a disconnect between the general practitioners and others. Tony, did you have another follow-up question, my friend?
You said about working towards about Australia-wide detection to be rolled out. What's the thoughts around that?
So when I mentioned a register, what we're really trying to do is to eliminate the risks of misinterpretation of individual risks, and then also of PSA test results on the part of GPs. And, you know, our sense is, and what we're currently investigating, is whether technology can actually help us to eliminate some of those risks. It's a tremendous enabler, and probably never more so in this area of work, where, just to give you an example, Tony, the creation of a web-based application managed by an organisation like PCFA. We're probably the only organisation in the country who can do this work. As long as we get the inputs right and make sure that we monitor things fairly closely, we can actually create a far more organised testing program that issues reminders when we need to, that identifies PSA levels that exceed the threshold for that individual man's risks, and then triggers referrals through to specialists when required. So there are different ways that we can do this, and we're at the moment engaging in early conversations about what that could look like.
Tony, if I might, Peter, I think that was Peter mentioned, what we're seeing is a transition. So if you look at the title of the 2016 guidelines, they're actually about PSA, they're about PSA test.
Yeah.
Our draft guidelines are about guidelines for the early detection. We're looking, and we're hoping for a transition from a focus on testing to a focus on the early detection of prostate cancer, one which looks at risk assessment, looks at the utilization of PSA, looks at then, you know, where we're indicated as through the guidelines, through the use of new technology, replication of new technologies like NPMRI and a diagnostic pathway, an early detection pathway, which is a broadly based program, not just focused on a PSA test, but on a program of early detection. And that then can lead us to this, hopefully, to that shift from a discretionary testing type program that we've had to what Anne has been talking about, which is an organised testing program and a national focus on the early detection of prostate cancer. I mean, believe it or not, that if we get this through at the end of the year, and that's our hope, and that's our objective, and we are not going to rest until we do, we'll be the first jurisdiction globally to have guidelines on the early detection of prostate cancer. And I think that would be quite a thing, and we're going to do whatever we can to make sure it works. So, Tony, thanks for that. I'm just looking through if there are any other questions. There's a question for, John's got one, and a question for David. You mentioned publication bias.
David, you mentioned publication bias as something to be aware of in the process. Could you expand on a little? Okay, yes. So publication bias is one of those issues that that we as epidemiologists are kind of aware of. Where often only the sort of the positive pieces of science get published, because there's always competition for the scarce space in medical journals, and so part of the issue around what we do go through the process is to ensure that we're picking up, you know, the positive stories as well as the negative ones. The process that we use is essentially going through, searching diligently through a number of different databases, and we've tended for this particular purpose to choose on what we call randomized controlled trials, which is the highest level of evidence, so that we're not cluttered with a lot of small studies that may not be of any relevance to the Australian context. So it's a sweet spot to ensure we've got everything, but we haven't got too much background noise that really is of no relevance to Australia.
All right. Thanks, David. Peter, I'll throw to you in a minute, because there's a question about DRE in primary health. That's from members of the Prosper Support Group. But before that, there's a couple of comments about GPs and about educating GPs and about consistent application of guidelines. Look, we couldn't agree more. So if you look at the actual draft pack, so the key implementation priorities are about engagement with GPs, about GP education, about involvement with them in our awareness programs. Right from the start of this process, we've been working with the Royal Australian College of General Practitioners and members, GP members on our expert advisory panel. In fact, they're, after consumers, they're the single largest individual group, as I recall, together with, consumers, GPs, and then urologists, I think, in terms of the numbers of people on our expert advisory panels. So GPs are critical to us. As Peter mentioned a minute ago, we've been keeping very close to them. Peter and I have a meeting on Monday with the college. I think it's prime in our minds. And I think if you wanted to do something right now, which would help us with this, if that's important to you, do take the opportunity through the consultation process to put that through. Because what we are obliged to do is report back to the NH and MRC on all these contributions. And if, there's so much attention to the notion of education for general practice, it strengthens our case when we get to implementation and when we get to getting funding for that. And please take the opportunity. Peter, can you pick up the question in there about DRE?
Sure. Following feedback from the first public consultation and also feedback from the webinar, and from also feedback we've received electronically, we have added extra notes to the DRE recommendation. But we do stand by the literature which shows very clearly that a rectal examination in a general practitioner's office is not that helpful. In fact, it causes a lot of unnecessary referrals and diagnosis and concern. And I know that from personal experience as a urologist, that's my trade. And we're often very wrong how a rectal examination feels in the rooms. So the first thing about DRE is that it's, if you look at it purely as a test to pick up prostate cancer, it's not very good. This is in asymptomatic men, okay? Now, you'll have seen from David's presentation too, one of the important parts of this whole process is applicability and acceptability by the population. And a lot of men are discouraged from coming for early diagnosis because of the thought of a DRE. So we felt on balance, we still should stay with the 2016 recommendation of not mandating a rectal examination. But in view of the feedback we've got from you guys and girls, we have added an extra statement. And I'm sorry, I've been looking for it in front of me, but along the lines of that if a patient, once a patient is referred to a specialist, or if the patient is complaining of symptoms, or if the patient wishes, by all means, a DRE is part of that workup.
All right. Thanks, Peter. We've got a couple of hands up here. So why don't we try one of those before we come back to chat? John Trelaw, why don't we start there and then we'll move on. G'day, John.
Hello, and thank you for the opportunity. I won't take too long. Thanks to all of you. May I say how good it is to see you looking well, Jeff. Very pleased about that. Thank you for your presentations and enormous work, which is, I think, just so impressive, the amount of work that's been done. My question is about the GPs. Critical level of getting the GPs to implement the guidelines. My question is, what research has been done about the discussion that a GP has with a fellow who makes inquiry about prostate cancer testing or PSA testing? It's always struck me with the time constraints in general practice that to actually have a discussion which is timely, comprehensive, and unbiased is very difficult. What research has there been at this level, which for me is absolutely critical, because so often we see bad reports of very brief consultations or put-offs from general practitioners whether that's right or wrong.
Well, you're right, John, and you raise again a very important point. So it needs to be critical in our education programs and in our future research priorities about implementation. So we have that down as an implementation priority in future research. I think where we have to work is, again, very closely with the college about how do we work with your members to make sure that we get some consistency in relation to what's happening nationally. And secondly, it's about making sure that the right decisional aid support is available to support the GP in their practice at the same time as supporting those individual patients when they come into a GP practice and are interested in discussing or talking about prostate health. Remember, we've changed the guidelines a bit because if the guidelines are implemented, currently there's no encouragement, and in some cases the opposite, as you know, for a GP to raise the matter. What the current guidelines recommend is that for men 50 to 69, is that the GP does offer, does instigate. So it is a change. And what we've got to try and do is get that into general practice sort of nationally. And I don't know if you've got anything you'd like to add to that in terms of the things we've spoken about.
Simply just to, I think, reiterate the point that technology can mitigate a lot of these risks and solve some of our problems here. It's human error. The risk of misinterpreting a man's individual risks or misinterpreting his results and what you need to do with them is one of the factors that influences, I think, survival and mortality rates in this country, which is why if we can look at the opportunities of technology and what they can do, I think that's really important. You'll see that Monica has just asked a question in the chat about the opportunities made available to women when we undergo cancer screening and the vast difference between how proactive we are in encouraging women and reminding them and in sorting it out for them versus what we're doing for men with prostate cancer at the moment. In fact, I was talking to a young man in our community who's just recently been diagnosed at the age of 36. And he said to me, men don't even get a pamphlet. And it's so true. It is so true. You know, one of the things that we can look at if we want to talk about cost efficiencies and the structures that are already in place, and there's no reason why we can't look at this. It may not work out, but we should examine it, is even the opportunity to couple breast screening clinics with prostate cancer testing. You know, so you would have a prostate and breast cancer clinic. It would just be for PSA testing. We wouldn't need to call it screening, which makes the Department of Health nervous, but there are many things that we can do, and we are canvassing all of those options to make sure that we come up with ways of eliminating the risks of human error, GP error, misunderstandings in this process. And I just want to impress on everybody how important technology can be for us in making this real. And I say that on the basis that I've been working with the telenursing team and prostate cancer specialist nurses for the last 5 years who hear every day the horror stories of men who've been misdirected or discouraged from getting PSA tests and then get a late diagnosis. What these new guidelines do is give us the opportunity to prevent the late diagnosis of cancer, prostate cancer. And for us to take hold of that and run with it, I think we need to look at new ways of doing things where we can.
Yes, thank you, Anne. Thanks, John, for the question. John, is that hand up, John?
Yes. In a recent YouTube call on the new guidelines, you made reference to there being a large number of late detection prostate cancer, and you linked it to active surveillance. I'm having difficulty understanding how active surveillance will reduce the number of late detections. I just don't see the connection, and I don't see how you're going to reduce the number of late detections by having active surveillance. Now, maybe I've misinterpreted what you said, but it just didn't ring as a logical conclusion.
Well, you're right. So I'm sure that you didn't misunderstand it, but maybe I didn't communicate it well. So what we want to do is reduce the number of prostate cancers that are detected later stage, which the guidelines will help us do. A part of the changes in the guidelines were about uptake and active surveillance.
The confusion may be that what we tend to talk about is what we needed to do and where the evidence has taken us now is mitigating the risks of overdiagnosis and overtreatment. And that's what active surveillance has allowed us to do. So 80% of Australian men with low risk prostate cancers now go on to active surveillance. The introduction of MPMRI has also allowed us to reduce the number of avoidable biopsies that we have to give in this country. So we've got a whole new framework for being able to detect prostate cancer and then manage it responsibly once we do detect it, and that changes things for us. There is a question in the chat too about what we can do for men who are undergoing active surveillance and experiencing the psychological distress of that.
Yeah.
We can only encourage you to please call 1-800-2200-99 and ask to speak with one of our counsellors or our telenurses. That's exactly what we're here for, and we recognise that what you're going through is really tough. It's not easy.
Really tough.
But stay close to us. That's why we exist as an organisation. Connect with a support group, seek our help. Yeah.
Right. I see Peter's got his head up just before that. So, Anne, thanks for acknowledging the chat note about support. So thank you for doing that. John, does that sort of add, so the active surveillance is part of a package rather than a direct line? And if I didn't make that distinction clear, I'll certainly make sure I do so in future. Peter?
Just to add to that discussion, Jeff, active surveillance, the term we use active surveillance very, very precisely. It's a term for men who've already been diagnosed with prostate cancer, who have low risk prostate cancer that we don't think needs active treatment at any time soon. And so the whole point of that, the biggest criticism of PSA testing pre-2018, pre-2016 was that it caused harm. In other words, a lot of men were unnecessarily diagnosed. There was too much diagnosis, too many biopsies, and so the harms outweighed the benefits.
Yeah,
What's changed since 2016 and 18 is the MRI, transperineal biopsies, and active surveillance, which has decreased harm. So all of a sudden, and we know that the benefits are better established, more published data is better. So all of a sudden, the benefits are better than the harm. So that's been the change. But active surveillance is just one part of that.
All right. Thanks. And thanks again for raising that, John. I appreciate it because it has clarified things. There's quite a bit of stuff in the chat box, in the chat room. Peter, we'll just go through. There's one thing about the saliva test. Did you want to just cover that? Or, Anne, I mean, it's just been in the media recently, but just...
I was just typing into the chat a response,
okay.
Monica, simply to say that the findings from that research are tremendously exciting, but more research is required to actually bring that test to market. So it's not quite there yet, but certainly if a saliva test for prostate cancer does become available, you can feel assured that it will be in Australia before too long at all. And certainly there's lots of research going on in that area in Australia as well as the UK, which is where that study came from. I'll share the link in the chat.
Yes, Peter?
Yes, I think it was Tony's just brought up he's having his MRI for active surveillance shortly. Good on you, mate. Let me tell you, as a practicing urologist, active surveillance has changed dramatically from we're not sure who should have it, how safe it is, to now, as the longer term studies come out, for low risk Gleason 6 disease, it's fantastic. It's very, very safe. It saves a lot of problems. And we as urologists feel a lot more comfortable about offering that to patients. Hopefully that'll transfer to you as patients and consumers being more confident about staying on active surveillance. But as Anne said, use that 1-800-1-800-2200-99 anytime. It's a great service.
Yeah. Peter, thank you for that. Look, we're getting towards the end and we're going to have to wrap up. Can I make 2 points? First of all, there's a couple of comments in there about the importance of partners in a whole range of ways, and we accept that. And, you know, certainly our consumer companions and all of those materials will reinforce that. It is that issue, isn't it, about men's health? I mean, there's a comment in there about men walking past the pamphlets, etc. And we know that. We've got to keep it up. Together, we've just got to keep it up and do whatever we can to try and swing that pendulum to make greater impact. We probably do need, we do need to finish at 3:30. So with your permission, what we will do is we'll look through the chat. Anything we any questions or thoughts or comments we haven't got to, we will respond to, and we make that available through the network, which we did from the last one as well. So please do that. If you find that when we finish this up, there are questions you wanted to ask or questions you think of subsequently, please do let us know. I mean, Kerry White got on to me last time about something he just didn't get a chance to ask, and we had a terrific discussion beforehand about certain issues he wanted to talk through, which is what we like to hear from you. So please send a note through to research@pcfa.org.au. But by way of summary again, remember we have another week or so before we close the public consultation timeframe. So that's midnight on Sunday the 25th. So if you haven't put one in and you'd like to, please do. Give us your thoughts. From here, the timeline is we close the public consultation, then Peter, David, Anne, myself, and the technical teams, the expert advisory panels, and the project steering committees then have a power of work on for a month, and we have to submit this to the NHMRC in a final version at the end of June for consideration at their council meeting in August, when we hope we will get approval and we will start to roll out. And then we get into the implementation priorities, and we are very looking forward to that process where we deliver for Australia, clinical guidelines or guidelines for early detection of prostate cancer in an organised and comprehensive fashion. Ones that are built around risk assessment, harm minimisation, and a transition from a focus just on testing to one on early detection. Make sure we get this disease as early as possible. And I think as Anne and the PCFA and everyone associated with it will keep talking about our vision, is zero deaths from prostate cancer. Let's make sure that we detect it early enough so that we can manage this disease and we don't start getting people coming to us with late stage. That's our hope. That's what we must do. Can I again, on behalf of PCFA, I note that our national chair was on the call too, which was nice to see. Eddie Steve. Can I thank each and every one of you for your interest, encourage you in your endeavours, and please do feel free to put in a consultation. And also, again, on behalf of PCFA and all the men and all those partners and all those family members who benefit from your work, to record without reservation a generous thank you for what each and every one of you do out there in raising awareness, helping us raise funds, educating the public, educating the professionals. It's going to take all of us to bring about this change, and I get a nice sense of collaboration and optimism from this call. So thank you one and all. If any queries, please do come back to us. Thank you, Peter. Thank you, David, for sharing your valuable time and expertise. And thank you, as always, Anne Savage, CEO. Everyone, enjoy your afternoon and have a great weekend, Dave.
Thanks.
Bye-bye.
Thanks, everybody.